Without wasting time, I am giving the big task of introducing Dr. Robert Bartlett. Who does not know Robert Bartlett? It is just like showing a lamp to a sun. So uh, the talk is about to begin, and over to the talk, please.
And I'm going to tell you a bit about the possibility of portable Ecmo or wearable Ecmo for respiratory failure in adult patients. In adult respiratory failure, about 70% of veno-venous cases have either recovered or died by day 14. However, about 30% of patients are still alive on ECMO with poor lung function at day 14. In the past, most of these patients simply died of right heart failure eventually. But now, since the onset of the management technique known as ECMO 2, Awake Alert ECMO, many patients recover and survive after months on ECMO. These patients could be managed out of the ICU with either portable ECMO or even wearable ECMO. If we take standard ECMO out of the ICU to step-down units, we would design an intermediate care unit where the standard ECMO equipment is used. Patients are alert and awake off the ventilator. The nursing ratio is 4 to 6 nurses to 1 patient, like a VAD or cardiac monitoring. Management and emergency protocols need to be developed to handle the potential problems. Patients are on a regular rehab schedule and recovery is still expected in another 1 or 2 months. Possibility would be to send those patients home with appropriate caregiver instruction. However, there are patients that recover months later with BV ECMO. There are hundreds of cases in the registry. There are specific case reports, and there are case reports of patients recovering after 35, 65, 155, even 605 days of management on ECMO. So we have to redefine what constitutes irreversible lung injury. We've learned has rather unexpected regenerative capacity during prolonged ECMO support, which may be months, even a year of duration. In late follow-up, these patients have minimal disability. This offers new scientific opportunities. Why does this happen, and how can we detect it? And it brings up new practical problems. Certainly, those patients will not stay in the ICU for a year or more. It's very expensive. So it's worth investigating the possibility of wearable, portable artificial lungs. Devices like this must be capable of total support in most instances. It can be done from the pulmonary artery to the left atrium or pumped by the VV. We'll talk more about that. In one particular application, pure CO2 retention, like end-stage COPD, this can be accomplished with very low blood flow and arteriovenous access. And of course, the limitations are clotting, bleeding, and embolism. So there are 5 approaches to developing a wearable artificial lung that are shown here related to the access and what they can accomplish. Notice mostly the red zeros. So AV access cannot provide oxygenation, does not treat the right ventricle, and does not use a pump. It's really used for COPD only. Venous access through a double lumen catheter does not treat the right ventricle, and PA to LA access does not require a pump. This is not new. This is a case from 2007. Aloy Philippe from Regensburg with a catheter, a device attached to the pulmonary artery and left atrium, bridging this patient to transplant. Other devices have been developed. This is the LevaNova Protect Duo device, which is a venous access attached to a catheter that drains the right atrium and infuses into the pulmonary artery. This is the idea of a PA to LA via thoracotomy rather than an intravascular catheter. This is shown here from Pittsburgh, but there are several others. Here is another, the same idea, PRA to PA total support, developed at the University of Maryland, applied through a direct thoracotomy, as shown here. This device is now commercially available as the Breathe artificial lung developed by Abiomed. They plan to make it even smaller and wearable as a backpack. So wearable artificial lungs, first of all, are not implantable artificial lungs. They'll always have to be pericorporeal because they're going to have to be changed from time to time, but it would allow management of patients out of the ICU, probably in very specific lung centers that are going to manage these devices. The future characteristics will be paracorporeal, as I mentioned, non-thrombogenic surfaces to eliminate anticoagulation. Our laboratory is developing microfluidic designs where the oxygen area is about the size of your thumb. The risks, of course, are exsanguination if it pulls apart from the AV fistula, and transplantation, lung recovery, and destination are palpable, which would be done in specific lung centers for patients who have not recovered after 2 or 3 weeks on Ecmo. And now we're going to stop the sharing and we're going to stop the recording.
To the next session, the speaker is to introduce. He is Dr. Suresh Rao, who director of the Institute of Heart and Lung Transplant and Gen Healthcare Chennai. And his areas of interest is heart and lung transplantation, circulatory support system, services, Ecmo, and cardiac critical care. He has published more than 30 national and international journals. He's authorized chapters in national and international festivals. His special experience is the president in the Association of Cardiovascular and Thoracic Anesthesiologists. He's president at the Society of India. Managed more than 500 heart and lung transplants and more than 50 LVDs. He's a recipient of Janak Mehta Award for Best Scientific Study, Vocational Excellence Award by Lions Club, and conducted several national and international. So he's going to speak on my experience, management of right heart failure during long VECO, role of moving nitrogen. Dr. Suresh.
Yeah, thank you for the kind introduction. And it's an honor to be here, especially speaking after Dr. Bartlett. Uh, that is MGM Healthcare, the hospital where we are involved in heart and lung transplantation, ECMOs, and implantation of various mechanical circulatory support devices and their management. We would have done around more than 450 ECMOs. That includes both veno-arterial and veno-venous ECMO. Now the question before us is whether nitric oxide has a role in the management of right heart failure in patients who are on long duration ECMO. So I will start with one of our case, a 40-year young man weighing 120 kg came to the emergency department with progressive dyspnea for 3 weeks. The CT scan done and the nasal swab indicative of COVID-19 pneumonia. There is no evidence of pulmonary embolism. Patient had persistent desaturation. He was intubated, put on ventilator, and paralyzed. We tried prone positioning, but there was progressive refractory hypoxemia. So we had no other way but to put him on veno-venous ECMO. He had acute renal injury, required renal replacement therapy, and he was on a VV Ecmo for almost 1 month, and his oxygen saturations were around 90 to 95%. But after 1 month, the saturation gradually came down. It became 80% and it was coming down further. Now, what is the reason for hypoxemia? As previous speakers said, there are various causes. It may be issues with the ECMO circuit or issues with the patient. So this flow chart actually helps us looking at various causes of hypoxia. It may be related to sweet gas flow or related to oxygenator, condensated oxygenator, which may require a production of cough oxygenator, or there may be clots which may require increased anticoagulation or change of oxygenator. The other thing is to look at the ECMO flow to cardiac output ratio. If the ECMO flow is less, you can increase it. But you can have a situation where the cardiac output is high, maybe because of severe vasodilatation. So the ratio is altered. In this case, you have to reduce the cardiac output. Probably you can use vasopressors to increase the LV flow. The other thing is major cause for hypoxemia is recirculation. It may be because of the cannula suboptimal position, which can be again repositioned, or it may be because of right ventricular failure. Right ventricular failure can cause recirculation. So, what are the effects of RV dysfunction? First thing is the cardiac output is reduced, so obviously oxygen flux is reduced. The second thing is as the right ventricular cardiac output comes down, the recirculation becomes more. Suppose if there is no cardiac output from the right ventricle, the recirculation will be 100%. So, RV dysfunction can produce severe hypoxemia because of the recirculation. So, next question is why RV dysfunction? It may be because of the increased RV afterload. Obviously, when there is a lung disease, the PA pressure can go up, or any injury to the right ventricle, it may be ischemic or tachycardia induced. Tachycardia actually increases the stroke work index of the right ventricle. It increases the RV free wall tension. So all these may result in severe right ventricular dysfunction. So the important thing, we know that the pulmonary arterial hypertension causes increased RV overload, thus resulting in RV dysfunction. So in this case, we looked at the recirculation fraction. To begin with, it was 20%, but now it has increased to 59% despite optimal caloric position. We looked at the echo, the LVEF was normal, RVSP was 60 millimeter of mercury. So we optimized the ventilation, gave IV sildenafil, iloprost, ambrisentan. There was no response. So what is next? Now nitric oxide is a naturally occurring vasodilator. It is produced by the pulmonary endothelial cells, and it has been found that the patients with pulmonary arterial hypertension, the expression of nitric oxide was less. So in these patients, if you give nitric oxide, it causes pulmonary vasodilatation and reduces the pulmonary artery pressure. However, studies have also found in some cases there is no reduced expression of nitric oxide, even though they have pulmonary arterial hypertension. So these patients will not respond to nitric oxide. So they are called non-responders. So in any patient, if the PVR is reduced more than 30%, or mean pulmonary artery pressure is reduced more than 12%, those patients are called responders. Now, currently, nitric oxide is approved for treatment of pulmonary arterial hypertension in neonates. Now, what happens with reduced nitric oxide expression? There will be impaired myocardial biogenesis and also impaired oxygen sensing, producing hypoxia. So several studies have shown the beneficial effect of nitric oxide in improving the oxygen saturation as well as reducing the pulmonary arterial pressure in patients with the ARDS. So we know that all the patients are not responders. 30% of the patients are responders. And what dose? Now, if you give up to 20 parts per million of nitric oxide, it will have beneficial effects. But if you use more than that, there is no significant difference. And nitric oxide doesn't cause systemic vasodilatation, unlike IV prostacyclin. And usually, this action lasts for few hours. But in some patients, it may last for weeks also, and we don't know the exact reason. Now, what about the inhaled prostacyclin? When you compare nitric oxide and inhaled prostacyclin, usually inhaled prostacyclin acts when there is a good tidal volume. You may require 500 ml per breath tidal volume for appropriate distribution of the prostacyclin into the alveoli. And usually these patients on Ecmo, we don't give high tidal volume. Obviously, it will cause barotrauma, more lung injury. So in these kind of settings where we are giving lesser tidal volume, nitric oxide is a better pulmonary vasodilator, and it is the first line therapy. Uh, Rolf et al. Actually they studied the role of inhaled nitric oxide in patients with adult respiratory distress syndrome, and they concluded that it reduces the pulmonary arterial pressure without causing much systemic vasodilatation. This is our patient. To begin with, his recirculation fraction was 20%, and oxygen PO2 was around 48-50. And after 1 month, the recirculation fraction increased to near 50s. That is the time he had hypoxia. And after starting the nitric oxide, gradually the recirculation fraction came down, and within 24 hours it came to the baseline, and the oxygen saturation also started improving. I think our previous speaker has talked about the recirculation index and how to calculate that. This is again a study by Rees et al. They looked at the effect of low dose nitric oxide for persistent pulmonary artery hypertension, and they followed up for 1 year in neonates, and they found that the nitric oxide reduces the requirement for VV Ecmo without altering the adverse events. This is the case where we use the nitric oxide. You can see the circuit connection of the nitric oxide into the breathing circuit. And the same gentleman was on ECMO for 40 days, and he had the pulmonary artery hypertension at the 30th day, and he responded. Finally, we could decannulate after 40 days. Unfortunately, he had one more episode of pneumonia after 10 days. So we had to put back the cannula, restarted the ECMO, VV ECMO, and this time he was on VV ECMO for 7 days, and finally we could wean off the ECMO. In fact, we invited him for the inauguration of the last annual conference of the Ecmo Society of India, and he has a good, almost near normal respiratory function. So to conclude, nitric oxide causes pulmonary vasodilatation without causing systemic hypotension, and recirculation index is reduced with nitric oxide administration, and only 30% of the patients respond to nitric oxide, not all patients. And there is not much benefit giving nitric oxide beyond 20 parts per million. And usually maximum benefit is seen within 24 hours. If there is no response, there is no point in continuing the nitric oxide more than 24 hours. So that is our heart and lung team. They are involved in the heart and lung transplant. and the ECMO management. Thank you.
Cardiac science and cardiac surgery at Med Super Specialty Hospital, Saket, India. At the outset, I would like to thank the organizers and Dr. Vivek for giving this opportunity to me. So, I'm a cardiac surgeon. You have been discussing about the venous ECMO so far. So, I'll be just shifting the gear, shifting the mood. So, I'll be just talking to you about the arterial ECMO. So, how we are using this VA ECMO for our LVAD patients, and what are the indications of how we manage it. So we all understand that the ECMO has to be used, has the indications for the cardiac reasons as well as for the respiratory reasons. For the respiratory causes, whenever we are using it is mostly EV ECMO, and for the cardiac causes, whenever we are using it is a VA ECMO most of the time. So what are the indications of VA ECMO? It is post cardiotomy most of the time when we are able to unable to wean the patient after the cardiopulmonary bypass, advanced heart failure, cardiogenic shock, patient with profound depression or overdose of toxic substances or in sepsis, myocarditis, and decompensated cardiomyopathy, and patient as a bridge to LVAD or heart transplant, and post cardiac transplant when there is a primary graft failure. So ECMO is a bridge to LVAD is used in the advanced heart failure patients where we use as a bridge to LVAD or bridge to transplant. So advanced heart failure, if you look at the prevalence of it, around 64.3 million people worldwide suffer from heart failure, and 1 to 2% general population of India suffers from heart failure, and 10% of that suffers from advanced heart failure. And what is advanced heart failure according to European Society of Cardiology? When the persistence of symptoms of heart failure stay despite guideline-directed medical therapy, and when the patient is in Intermax 1 to 7 or in NYHA 3 and 4, patient has got isolated right heart failure, patient with malignant arrhythmia, 6-minute walk test of less than 300 meters, and peak oxygen consumption of 12 to 14 ml per kg per minute. So according to Intermax, this is the Intermax classification. So if we say NYHA 3 and 4 for advanced heart failure have been divided into Intermax 7. So Intermax 1 is the most sickest patient. They are like crash and burn. Those patients are crashing despite all kind of treatment. And Intermax 2 is the prolonged decline. They are patients which are sliding on inotropes. Intermax 3 are dependent on inotropes. And number 4 are frequent flyers. So these are the patients which are in and out of the hospital. So these Intermax 1 to 4 are the most of the patients where we may require ECMO as a bridge for LVAD therapy. So higher the, or you can say the lower the Intermax class, poorer the prognosis is. So these patients require ECMO support so that what we can do, we can optimize these patients for putting them on LVAD or putting them on heart transplant. So therapeutic options for the heart for the advanced heart failure and medical management. There have been advancement in medical management. We have newer drugs now which we can manage advanced failure with these drugs. So ARNI and Vericigot and all other new medicines can really help the patients in improving their clinical conditions. Then there are devices like CRTD and MicroClip where we can support these patients on these devices once the medical therapy has failed. But despite all these patients keep on deteriorating, and then LVAD and heart transplant remain the choice for these patients. So ECMO as a bridge is a reasonable strategy because outcome of heart transplant LVAD are highly dependent on the clinical status at the time of the surgery. The how sick the patient is, sicker the patient, the worse outcomes we are going to have. And it depends on the Intermax class, as I just said. The lower the Intermax class, worse the prognosis is. And pre-transplant or pre-LVAD implant, clinical instability of the patient is a strong predictor of the negative outcome of heart transplant in LVAD patients. So, what ECMO does, ECMO gives a time to us. We can stabilize a sick patient for LVAD or heart transplant. It allows the time for hemodynamic stabilization and end organ damage if there is some renal dysfunction, hepatic dysfunction, or other organ dysfunction. It gives time for recovery to end organs, and it gives us a thorough evaluation time for evaluating these patients for heart transplant candidacy. So Ecmo is as a bridging strategy for both ALVAD as heart transplant has increased. Initially at 2007, this Ecmo as a bridge to ALVAD was almost zero, but now it is almost like 5% of the patient would be bridged by Ecmo when they require ALVAD. So this has been, according to the UNOS and Intermax registry, these are the patients who require ECMO support before putting them on LVAD or heart transplant, which almost is 5%. So there have been recently changed that these patients generally do not require, I would say, the ECMO support for LVAD, and more of them would require support for the transplant because there's organ allocation system has improved in the West. But whereas in India it remains the same, and it remains a problem there. So the patient selection, what are the predictors? The age of the patient, BMI of the patient, serum creatinine, and the bilirubin, and the right heart function. They're all poor markers for the patient for the mortality. And this is the flow chart what we follow. Patient with low cardiac output will require short-term mechanical support. If he recovers with short-term mechanical support or ECMO, then we give medical therapy. Otherwise, this patient is either for a heart transplant or the patient is for the bridge to transplant. And so what are the predictors of mortality in these patients? The patient with old age, female sex, diabetes, pre-existing coronary disease, elevated lactate levels, and prior cardiopulmonary resuscitation is a poor predictor for ECMO. And the ECMO or LVAD group need for the right ventricular assist device is a significant predictor of mortality because if these patients have got right heart failure or the indications for right heart failure, they have the poor prognosis. So hemodynamic parameters and scores like pulmonary artery pressure index, right ventricular stroke work index are better indicators for the ECMO support. Patients with poor right heart functions are likely to benefit from the transplant when possible rather than their candidates for the LVAD. So if we look at these two, the patient who are above 60%, 60 years of age, patient with BMI of more than 30, creatinine levels are more than 1.5, and bilirubin level are more than 2. These patients have got LVAD is a favorable device or a strategy to choose after ECMO bridging. And if these patients have got age which is less than 60, BMI less than 30, creatinine less than 1.5, or bilirubin less than 2. So if we bridge them with ECMO, the transplant is a favorable outcome in these patients. So this is a study which was published in 2021 where they compared ECMO as a bridge for LVAD as well as for heart transplant. And they found that ECMO as a bridge for LVADs is non-inferior. They could not establish the superiority because the number of the patient was around 900 in this study. So they could not establish the superiority, but they said it was non-inferior. So we can still continue to use ECMO as a bridge for the LVAD patients. So, what are the problems or what are the challenges what we face? Some of them are specific to the VA ECMOs. Basically, bleeding when the patient we are keeping these patients for prolonged support, bleeding, coagulopathy, thrombocytopenia, and non-pulsatile perfusion of end organs is one of the problems what we feel in these patients. And mechanical complications, air embolism or thromboembolism, neurological or intracerebral bleeds is another problem. And what there is one specific problem what we face in the patients who have got who are on VA ECMO is leg ischemia. Because if we are not careful about, or if we are not taking care of the leg perfusion, these patients are bound to get leg ischemia if they are on a prolonged ECMO support. So for this, what we have to do, either we have to put a smaller cannula in these patients, or we have to always put a cannula for distal perfusion. We always have to be careful that we have to put a cannula so that we can perfuse the leg. So this is what we do in our patients. We always put a perfusion cannula to perfuse the leg. And if these patients develop compartment syndrome, we have to do a early fasciotomy in these patients so that the leg ischemia does not happen in these patients. So this is I mean, how we do it. This is a cannula which you can see we insert it in the femoral artery and for the distal perfusion for the leg, and then there is cannula going proximally, and with a arterial line we attach this, and this causes from there only you take the blood to perfuse the distal leg. And this is a biflow arterial cannula which we have introduced recently. So this cannula has an elbow where it has got a bidirectional flow. So most of its flow go in the proximal direction, but some flow goes in the distal direction. So that this cannula, I mean, we have used in a few of our patients have found that for the VA ECMO this also helps and decreases the complications. So this is like this. You can see there is a hole at the elbow, and this is a 19 French cannula which is giving a forward flow, and the 6 French there is a hole which gives a reverse flow. So I mean at this, by doing this we can have a limb perfusion at the same time. Let's see, there is a video here if we can show. So you can see that we just run it on the table. We see that there is a forward flow and there is a backward flow uh, which can cause limb perfusion and avoid limb ischemia. So to conclude, I will say the heart failure patients with cardiogenic shock requiring ECMO is a bridge for LVAD as well as heart transplant. And it is in the high risk patient, it is a strategy what should be adopted. However, bridging to LVAD may be a non-inferior approach. There is no clear-cut evidence, but around 5% of the patients are being bridged by ECMO before LVAD. Newer organ allocation strategies are required, which are shifting more patients after ECMO to heart transplant. But ECMO to LVAD is also a strategy which can especially be useful for patients who are being done in India. And with the advent of newer durable HeartMate 3, the results appear to be significantly better because HeartMate 3, because the study which I quoted had used HeartMate 2, which was a previous generation LVAD. So this is a newer generation LVAD where we can have a favorable outcome if we use ECMO as a bridge in these patients. Thank you very much.
University at Gold Coast, and he has got a special interest in pathophysiological cardiorespiratory failure and ongoing research program of the No Tube project aims to integrate less invasive respiratory support. He has published over and also registered scientific oversight committee. He is also a member of Asia Pacific ELSO Education Committee and a course director of an ELSO endorsed Ecmo course. Over to Dr. Singh.
Long kind introduction. Thank you. So I'm sure this is something we all think about from time to time in ECMO patients. So let's see what the consensus will be at the end of my lecture. And first of all, I'm very thankful for the organizers for the kind invite and the hospitality. So there was a time when we said no one should die without steroids in ICU, and now we're not talking about someone who's dying in front of us. We got someone we know in a ECMO who's sort of stuck. They're not moving forward. They got refractory lung condition, we believe, and the question is, should we give them steroids or do something else? So, I don't have any conflicts relevant to this lecture. Disclosures include sort of association with these organizations. As we know, ECMO is only a supportive therapy. It's not going to reverse our age. It's not going to make us young. It's not going to reverse our diabetes and heart disease. And it's only buys time to keep people alive while we try and fix the underlying problem, and hopefully we don't make the problem worse by what we do on the bedside. and it makes the number look a bit prettier for a period of time while we sort things out. And why do we actually do VV ECMO? And the biggest premise is not to improve oxygenation, obviously, it's to protect the lungs, which are already diseased, prevent multiple organ failure. If lung is the problem, why should other organs fail? Let's maintain other organ functions as best as we can, and also keep the rest of the patient in good shape. Let's do physio and rehabilitation. And ideally, if lungs don't get better, I would want a new set of lungs, of course. But it's more complicated than what I've said there in real life. And we typically try and fix the lungs with various things. Pharmacologically, we use all of these. I think my favorite is diuretics. Most people get better if you dry them out or remove some fluid. Obviously, we use antibiotics, immunomodulators, sedatives, especially with the respiratory drive, which has been spoken about earlier in the day. Modulating the respiratory drive is important. A variety of anti-inflammatory agents have been tried, as we know, in intensive care in the past and still are being tried of interest. Stem cells and anti-proliferative agents. So while the patient is on ECMO, you can try a range of things. If you're an enthusiastic person, you may try all of them. Or if you're a very conservative person, you may just buy time and chill and see what happens. So once again, to use most of these agents, we need some evidence. And the question now is, what do we do in the prolonged VV ECMO runs, especially given the challenges we face in this part of the world where we can't afford to have long runs in ICU. Financially, it's not viable, resource intense. Is there a shortcut? Is there something we can do to magically improve the lungs quickly? When it comes to steroids in ARDS patients on VV ECMO, there is no specific evidence I can quote, obviously. So question is, can we look at the data from ARDS patients who are not on ECMO and extrapolate it? We'll try and look into that. And then we'll try and make a case for steroids, and then we'll make a case against steroids, and let your wisdom prevail, and we'll see what you all think. We'll have a little show of hands in the end. So when we look at ARDS literature, there is some data that maybe early steroids is beneficial. Once again, it's heterogeneous trial populations, and also there's variability between the steroid use. For example, hydrocortisone versus dexamethasone or methylpred. But many believe that there may be some benefit early steroids, and this joint task force in 2017 did recommend up to 7 days of onset a milligram per kilo of methylpred, and for later onset they recommended 2 milligrams per kilo. They warned us against rapid weaning. They asked us to wean slowly, and they thought methylpred is better because it penetrates the tissues well. And I'm not sure how many are using it, even in early RDS. There have been surveys done around the world, and not many are using it. There are some countries where people are using it religiously, so I don't know what you guys do in this part of the world. Does anyone use steroids for early RDS? Please throw your hands up. Not many, yeah, but yeah. And then based on that, most of us would believe that we need to balance risk and benefit. I think if you think it's a very steroid responsive condition and the risks are low, you probably go and give it. But for that, you need to have greater level of certainty. But that's what I do in my practice, and people I know around where I work do. One thing is for clear that if you give it too late, at least in patients with persistent ARDS, based on this trial, we have convincing data that after 14 days, probably it's not good, and especially there was increased harm. There was more deaths in that steroid group. So most people stop giving late steroids in the non-ECMO ARDS population. But that doesn't mean people have stopped doing it. Regardless of trials, often we end up doing what we want, but this is what the evidence says. So what is the case for steroids and prolonged ECMO runs? I think prolonged ECMO is challenging. There's clinical uncertainty. We never know. We're just buying time. How long do we wait? Months, years. So there's always uncertainty. There's always complications. It's not like a smooth run. Things keep happening, ups and downs, and it causes a lot of distress for the patient, family, including the staff members. Some of them become extremely cynical. Some are more optimistic. So there's always this pessimism around the patient. A lot of resources that get used. And often it can become a bridge to nowhere because we don't have enough lungs to transplant everyone. And more often than not, they're also not in a condition. We don't maintain them in a condition where they become eligible for lung transplant usually. So, but to make a case, obviously, I would rather want them to give some steroids and make them better quickly if possible. Equally, there is some indirect data. For example, if you look at these autopsy studies in large set of patients, at the top you see normal lungs with normal alveolar membranes, and there is middle there is the hyaline membrane, and then fibrosis in the lower image. So what we see is that in the early stages there is the exudation phase, and the alveoli fill up with fluid essentially. And as time goes on, there's more fibrosis, there is more proliferation. So there is some mechanistic data that suggests maybe as we get late into later stages, one can make a case for steroids, even though I'm seeing the evidence. And there's also data to show that people who had very little fibrosis with time had a better chance of survival, and extrapulmonary causes of ARDS seem to have less fibrosis compared to direct pulmonary causes. So if you got someone who's got ARDS from abdominal sepsis, they are less likely to benefit, if at all. And we also know pulmonary fibrosis correlates with outcomes. This is based on in the study in the 1990s. But more fibrosis, worse the outcome, which is very expected. And there's also some data that in that trial that showed there is no benefit of steroids in persistent ARDS. They also looked at the bronchoalveolar lavage sample, and based on the procollagen peptide, which is the prohormone that decides how much fibrosis happens in the lung, people who had higher levels of those had worse outcomes. So we can make an indirect case that maybe there is a case for steroids. And when it comes to lung transplantation, what happens typically in Ecmo is you don't think of transplantation on day one. So everything we do in the first few weeks pushes the patient towards bed-bound care, deconditioning, other complications. So they're really not in a territory where even transplantation could be considered. Often they have a lot of things going on. So it's often an afterthought. Good programs sometimes try and manage patients in such a way that they are not far from the transplant territory. And donor pool is obviously limiting. We don't want to put them on too early and limit their lifespan. If possible, we want to give them enough time. And the question then is, if the patient's not going to get transplanted anyway, uh, why not just give them steroids? So there's a lot that needs to be considered. And when it comes to a case against giving steroids, we always think of risks. Any drug for that matter, we always worry about risks. And we know there is a strong association between Ecmo duration and infection. And the question then is, by causing more infectious complications potentially, do steroids further prolong the Ecmo run or create infectious complications that may end up being the end of life? So these are the complications. Most of us know the complications of steroids. We're not going to run through each one of them. But one of the interesting things that can happen on ECMO is steroids can blunt the febrile response, and as we know on ECMO, the temperature is quite well regulated. So we may miss an infection, but equally, some argue that steroid may actually help you fight infection better. So there is mixed school of thought, and some also argue that prolonged steroids are better than a short course and rapid tapering. But there are complications associated with steroids we need to keep in mind. And also, when it comes to steroids, not all steroids are the same. This is something we need to keep in mind. So there are various people who argue that dexamethasone is the purest steroid you can get with minimal complications. So some swear by dexamethasone, but we need to understand the risks of steroids too. And this is the observational data that shows that patients with longer ECMO runs have a higher risk of infections, which has been proven time and again, and it's not a surprise, but there are multiple studies that have shown the same thing. And also patients with, not just long run, but if they also have other complications such as kidney injury, and they seem to have a greater risk of infection as well. Another thing that makes it all hard for us is we don't know what we're treating. Even though we are desperate and give steroids, hoping that something good will happen, we can't really figure out what we're treating. And imaging is often non-specific. It doesn't give you that level of specificity in terms of what's happening in the lung. You may see fibrosis. It may help you make some decisions. Clearly, having a negative growth in the bronchial sample, absence of infection will give you more confidence. Biopsy is too much of a risk. There are people who safely done transbronchial biopsies, but we don't do it in our center. It's just too much of a risk, and we may make the whole situation a lot more worse. And often the information doesn't, even if you went ahead and did a biopsy, you don't get a diagnosis all the time. Sometimes it's equivocal, and most people end up giving steroids anyway. So why go through the whole complications of a biopsy? Only exception could be COVID 19, something, because as we know, we all remember this famous figure when the COVID came along. There was this nice three-phase response. It's I don't know. There was people swore by steroids. Clearly, there was some benefit with steroids in the non-ECMO early stages of respiratory failure, but we still don't have data to show that steroids in ventilated patient is beneficial. So indirectly, once again, one can't confidently say it will help in patients on ECMO. But we all have seen this from time to time. I'm sure you would have seen as well. The post-COVID organizing pneumonia is a real deal. I think there's now a large amount of case series and observational data that's been built up. So it is a very dramatically steroid responsive condition. I've seen a few too, and most of them responded. But the interesting thing with them is the idea is to give it early and stop them from going on ECMO. Rarely you have to put them on ECMO just to buy time for steroids to work, but most of the cases we saw, we were very prompt and early with steroids, and most of them didn't need ECMO. So COVID may be an exception, but equally there is data in COVID as well that if you use steroids late, the outcomes may be worse. So depends on if you're a believer, you can find a bunch of case reports that will tell you it's a good thing to do, and if you're a non-believer, you can find a bunch of papers that will say it's probably not a good thing to do. So in the end, we'll have to look at the patient in front of us and try and make an assessment. And this is the unpublished data we analyzing at the moment based on the ELSO registry. This is across all the waves of the pandemic. It's observational data, so take it with a pinch of salt. But clearly, it shows that people who had steroids had a worse outcome. As I said, it's observational data. So, what do we make of all this? I think steroids in the longer ECMO runs remains a controversial issue, according to me. It comes down to our approach. If you believe that a drug only does good things and no harm, then we'll be more likely to give the drug. If you're worried about the risks, you're more likely to not give it and deliberate a lot more. So, in my mind, I think longer runs, if there is no recovery, if you're in a setup where transplantation is feasible, we should start preparing our patients for transplant. That would include ambulating them, reconditioning them, maintaining them in good shape, optimizing everything we can optimize, and start asking the question of the transplant doctors because transplant doctors take a long time to bond. So you need to get the referral early, get them to see the patient, and think transplant. Of course, our intention is to give the long run as possible because we know people lungs can recover after a very, very, very long run. People have given 3 months, 6 months, 8 months long runs, but that may not be feasible in everyone. I think the whole idea should be while the lungs rest and recover, we need to maintain our patients in best possible shape. If they are not a transplant candidate, by all means try steroids on a case by case basis as long as you're able to justify the risk versus benefits. And infection surveillance is the key if we are really thinking of steroids. The question then is probably there's a population that benefits from steroids. There's a population that benefits from every drug we know. There are also people who get harmed. So the whole trick is to figure out who are the ones who are going to benefit. We need some guidance from imaging, bronchial lavage, etc. to guide therapy, but unfortunately at this point in time we don't have that level of guidance. And probably at some stage, when we done such decent trials in the general ARDS population, we should also do trials of steroids in the VV ECMO population so that we have better answers. Thank you.
Do you really think that the pre-existing lung disease before the patient goes into ARDS is a strong determinant or any kind of determinant for a responder or a non-responder to steroids?
Yeah,
Is a determinant for responder or non-responder to the steroid during the ARDS?
it depends on if they are an underlying steroid responsive condition that got worse when they got other secondary infection in the RDS. Maybe the bronchospasm component that exists in respond, but there's no data to tell us that is the case. Yeah, that is what I know. I don't think there is. But clearly, the outcome should be worse if you already have underlying lung disease.
And there are a small number of patients who have positive autoantibodies who don't have clinical syndrome of autoimmune lung disease prior to commencement of ECMO. But as Kiran was alluding to, it gets kicked off by the presence of infection. And then once you've got the inflammation, and that persisting inflammation remains. And yes, some of those patients do respond very well to steroids. So I think there are some of the underlying conditions. And to be honest, in some of the conditions we're talking about, if you end up with somebody stuck on ECMO after several weeks or even several months, and if the patient is not an ECMO, is not a transplant candidate, then you're faced with a binary decision, which is steroids or withdrawal. And in my opinion, you often have nothing to lose from giving that patient steroids. And if they get better, great. And if they don't, then you know worse off. So it can be a binary thing.
Not the argument, it's a question of not dying versus steroids, it's more time versus steroids. What do you do then? What if they get better if you just give them another 6 weeks?
Well, you could also take the line with the terminal protection.
Absolutely.
I just wanted to give my observation as a continuation of this. Another infection by giving steroids. The problem comes when we find that the pathology is static. We have a prolonged ECMO run. The repeated cultures are coming negative, and we tend to, our impulse to give steroids and see. But all our experiences we have seen is the waiting that helps. The lung has a very good capacity to regenerate with time. And steroids, as Nick has pointed out, very, very minor cases where steroids might have a certain role. In others, I think we should avoid.
Yeah, you make a good point. You can sit with the family, tell them, look, we have these options in front of us. If they're, especially if the family is impatient and saying, we run out of money or we don't want it anymore, I think it comes down sitting with the family and at least we'll feel comfortable then before we make that binary decision. It's good to sort of consult the family and say, these are the two paths we can take and then make that.
Even in COVID-19, there was no trial with patients on ECMO for steroids. It was only the patients who were not on ECMO who were given steroids that
Yeah, I think we had a couple of patients who were on ECMO for almost a month and airlifted to our center for a transplant. So we just continued for ECMO for another 2 months because lungs were not available, and ultimately the lungs recovered. It is just sitting tight and managing them.
you
So, so what we did was, is there another, can we move on? Or we actually chatting?
Yeah, so sort of like
We can talk for hours.